Thank you.
Moving to your next in order, I believe it's item 10, SB 1300.
Thank you. Yes, Mr. Chair and members, this bill is intended to address inadequate Medi-Cal reimbursement rates for ambulance providers. As you know, I've carried numerous bills on this topic, and the main reason is because ambulance providers are required to see all patients, including Medi-Cal patients. They have no choice. Unlike a private practicing provider who chooses not to because of reimbursement rates, they don't have to. The rationale for the increase is that while the cost to provide ambulance services significantly increased during the past 17 years, Medi-Cal reimbursement rates have not kept pace. The last Medi-Cal rate increase was in 1999. The rates were reduced by 10% in September 2013. The current basic life support reimbursement rate amount is about $106.38 and is $11.82 lower than the rate in 1999. When I've done bills on this issue in the past, they've generally failed in suspense file. So this year, we're trying a different approach through a quality assurance fee similar to that one we have in hospitals, nursing facilities, and managed care plans. This bill is sponsored by 911 Ambulance Providers, Medical Alliance, with a coalition of 6 large ambulance providers. And with that, members, I have individuals who would like to speak in support of the bill.
Yes.
And I do have members, amendments, authors' amendments that address comment 9 in the analysis, and the sergeants are, I believe, have.
Yes, the mock-up, members should have the mock-up that reflects those amendments. I would encourage supporters, there's no opposition on file. We will limit the group to a total of 6 minutes, so presumably you've worked that out in advance. There's no opposition on file.
Johan Claes, representing Paramedics Plus, who is Alameda County's 911 EMS ambulance provider. We provide 100,000 transports per year. 34% of our transports are Medi-Cal. You've heard that these rates are back down to the 1999 levels. It costs about $600 to transport a patient, and only 16% of our transports have commercial insurance. We support the quality assurance fee and support the bill. Thank you.
Thank you.
Mr. Chairman and honorable members of the Senate Health Committee, my name is Harvey Hall. I have owned and operated Hall Ambulance Service for 45 years. I am also the president of the 911 Ambulance Providers Medi-Cal Alliance. The 911 Ambulance Providers Medi-Cal Alliance is the sponsor of SB 1300, authored by Senator Hernandez. The Alliance members provided emergency ambulance service to Californians more than 1 million times in 2014. More than 330,000 of those patients of that 1 million were Californians covered by Medi-Cal programs. Emergency ambulance providers have not seen an increase in reimbursement for 18 years. During those 18 years, we have actually seen rates cut twice. SB 1300 will help close the gap between the cost to provide emergency ambulance service and current Medi-Cal reimbursement rates. Let me share my business story with you. I started Hall Ambulance in 1971. I started with 1 ambulance and a few employees in Bakersfield. Today I have 92 ambulances, 1 air ambulance, and 412 employees operating from our main office in Bakersfield and 13 offices in rural communities throughout Kern County. I am very proud of the number of jobs created by Hall Ambulance. EMTs, paramedics, nurses, dispatchers, mechanics, facilities maintenance, and billing office staff received more than $22 million in compensation in 2014. Add taxes, employee health benefits, uniforms, medical equipment, disposable supplies, technology, and other ancillary expenses, and our footprint in Kern County is very deep and wide. In 1998, we received a Medi-Cal rate increase from $105 to $118 per transport. In 2008, we were cut to $116. In 2012, we were cut to $104. None of the expenses have gone down. Employee health benefits continue to skyrocket. Fuel costs have doubled. Vehicle costs increased annually, and costly technology mandates are handed down yearly. Hall Ambulance provides high-paying jobs for the community and operates highly sophisticated staffing programs to match the need for emergency ambulance. We also provide high-quality health services to everyone that needs 911 services, regardless of their insurance or ability to pay. We want to continue to serve both our employees and our communities. Over the last 18 years, emergency ambulance providers have tried to balance the difference between cost to provide service and Medi-Cal reimbursement with higher prices to commercial insurance customers. The model is not sustainable as more and more Californians are covered by Medi-Cal. Something has to change in order to keep ambulances appropriately staffed, equipped, and deployed to protect Californians. I thank you for the opportunity to speak today, and I urge you all to support SB 1300, and thank you, Senator Hernandez, for authorizing this bill.
Thank you, Mr. Hall. Thank you for your service to our community. Proponents, we have about 2 minutes left, so would ask you to be concise.
Jason Sark with American Medical Response. We move about 800,000 patients a year in the state of California. This bill will allow us that much needed buffer for us to be able to maintain these high performance systems and continue to implement all the new technologies that are coming online and are demanded from us, from both our patients and the counties that we serve. So we ask for your aye vote. Thank you.
Thank you. Others in support?
Jody Hicks with the Coalition, just here to answer questions. Thank you.
Thank you. Other witnesses in support, name and organization, please.
Bob Berry with Care Ambulance, and we are in support of the bill.
Thank you.
Catherine Brandenburg, representing the County of Alameda, in support.
Thank you. Seeing no other witnesses in support, is there any opposition to this bill? There's none on file. We have a motion from Senator Pan. This is do pass as amended to appropriations. Senator Hernandez, would you like to close?
Ask for an aye vote.
Please call the roll.
Hernandez? Aye. Hernandez, aye. Nguyen? Hall? Hall, aye. Mitchell? Mitchell, aye. Monning?
Aye.
Monning, aye. Nielsen? Pan? Aye. Pan, aye. Roth? Wolk?
So that's 5-0, enough to get out. We'll keep it open for absent members. Moving to the next item in order for Senator Hernandez, I believe, is item 12, SB 1365.
Yeah, thank you, Mr. Chair and members. This bill is intended to ensure that hospital facility fees stay where they belong at the hospital. For example, if you go see a physician at a doctor's office, the physician is paid a professional fee intended to cover the cost of the visit, including the overhead. But if the office where the physician is located is part of a hospital, there are two fees, the professional fee and the facility fee. The facility fee is intended to compensate the hospital for extra expenses that come with running that hospital, operating an emergency department, as an example. But sometimes that outpatient departments are miles away from the actual hospital and look indistinguishable from other medical office buildings. This bill will prohibit hospitals from charging facility fees when the outpatient department is not on the hospital campus. This bill came about me by the witness here, and I'll have them present. And with that, members, I respectfully ask for an aye vote.
Thank you. And before we go to supporters, again, we're working on a 6-minute collective time frame here. Thank you.
Mr. Chairman and members, Barry Broad on behalf of the Teamsters. We're the sponsors of the bill, and we came upon this. This is not often this has ever happened to me, in which I am the reason why what happened to me is what is the basis for this bill. And after it happened, we looked at it and found that this is an emerging trend and a problem nationwide that needs some attention. I am a patient of UC Davis Medical Center. I receive fabulous medical care and have been a patient for decades there. In the course of the advancing age of my body, a year ago, it turned out that I had a little arthritis in my knees, and they prescribed a specialty injectable for my knees, which is a series of 3 injections that was given to me at the sports medicine clinic of UC Davis. Those injections were pre-approved, and they were billed at about $1,300 an injection to my plan. 6 months later, it's time for the next set of 3 injections. They tell me, the sports medicine clinic is moved from J Street to C Street, a mile away and probably a mile further from the hospital. And it's just another office building. And I go there and I have the 3 injections, and each of these injections takes about a minute, and somebody walks in, it's in an examination room. It's not in a hospital. It doesn't look like, it's just an examination room. Like any patient, the bill arrives after the service. And for each of these $1,300 injections, suddenly a $2,500 facility fee was tacked on to each, which rose to $3,000 for the third one. And I have to pay 20% of that. The plan has to pay 80% of that. And it's like, what is this for? And I'm just a regular consumer here. I call up my plan, I go, what's this about? And they said, well, you got treated in the acute care hospital, and they attached the hospital fee to it, and, we pay 80% of hospital fees, and you pay 20%. And so then I started calling UC Davis, what's this for? I had no notice. I had no idea what the fee was. It was just there. And they basically said, well, it's a hospital-based clinic, and even though it looks the same and functions the same, it's not the same on our organizational chart. And apparently there's some difference in the electrical service or some other building things that they have to meet or something, but it looks pretty much the same, except that the roof was leaking on the day I went. So on the hospital, there was actually a bucket there, so it wasn't, exactly the same. In any case, I said, well, what's this based on? Is it based on a % of the service? Is it based on, what's it related to? Because the fee is more than twice the cost of the service. And they said, well, we don't really know. We're thinking about reviewing that. So it's apparently random. So we have these fees that are just assessed on people that aren't based on any rational basis. They're delivered in an outpatient clinic, which is an office building that is that's not the hospital.
May I
Right.
just
Right.
respectfully?
Yes, let me finish.
Respect for your colleagues.
I'll finish up. So, this ought to be based on something. We met with the Hospital Association. We appreciate there are issues. We think that we can work things out with them in this bill if it moves forward. There is probably some middle ground here, but there needs to be some rational basis for gigantic fees being attached for no additional service. So we urge an aye vote. Thank you.
Beth Capel on behalf of Health Access and also Unite Here. Unite Here, which represents hotel and casino workers, worked on a similar issue in Connecticut where Yale New Haven was busy gobbling up physician practices and increasing the fees that were adding facility fees. One of the victories we won there was site-neutral pricing, and so that was a very important thing. So when this was brought to our attention, we were happy to support the bill and to recognize that this is a problem not only here in California, but also across the country. And so pleased to be here in support.
Mr. Chair, members, Sarah Flocks, California Labor Federation. We are also in support.
Mr. Chair and members, Michelle Cabrera with SEIU California, just to say that hospital-based care is more expensive for a reason. We do have seismic safety standards. We do have nurse staffing ratios. We have 24/7 ERs. All of these things may merit an additional expense being added on, but when that care is not being delivered in the hospital where all of those conditions apply, patients shouldn't have to pick up that extra cost. And for those reasons, we're in support.
Thank you. Other witnesses in support, name and organization?
Yeah, John Winger on behalf of America's Health Insurance Plans in support.
Witnesses in opposition, do you want to come forward, please? Yeah, let's hear from opposition, and then we'll open it up. Okay, opponents, please.
Chairman and members, Barbara Glazer with the California Hospital Association. We are here today in opposition. We have had discussions with the author and his staff, and hopefully we can work things out, but the bill in its current condition simply does not work for us. The bill fails to recognize the role that hospital-based clinics play in the healthcare system. These particular facilities are part of a hospital's license and must comply with applicable laws and regulations. Hospital outpatient settings operate with higher cost structures due to greater regulatory requirements compared to physician offices or ambulatory surgery centers. These clinics adhere to rigorous standards for patient care, facility infrastructure, and operational procedures. These are not necessarily things that are obvious to a patient when he or she walks into one of these clinics. You know, the electricals, they meet different standards. The plumbing is different. All of this is in part why the facility fee is there. Also, the facility fee is part of the hospital, and it is, although inpatient fees are not charged to patients receiving outpatient services, but the hospital overhead is spread across all departments. So that is also why these fees exist. These hospital-based clinics exist in some settings where if it weren't for the resources and the infrastructure of the hospital, these services would not exist in a given community. Here with me today is Tim Curley from Valley Children's Hospital, and he's going to talk about their particular situation.
All right, thank you, Barb, and good evening to the committee chairperson and the members of the committee. Again, my name's Tim Curley, and I'm Director of Community and Government Relations at Valley Children's Healthcare in Madera. As one of the largest pediatric healthcare networks in the nation, Valley Children's is Central California's only pediatric healthcare network offering comprehensive healthcare to our region's sickest kids. We offer specialized medical and surgical services for some of the most unusual complex conditions you're going to see. Our network is anchored by a 358-bed specialty hospital in Madera and also 27 hospital-based specialty care outpatient clinics. Most of those outpatient clinics are located under the hospital roof. They're part of the hospital's integrated delivery system. Some of the clinics are located just across the street from the hospital in another building. In 2015, Valley Children's had over 13,000 inpatient cases or visits and had over 142,000 outpatient visits in our outpatient clinics. Medi-Cal covered 77% of those inpatient cases and 75% of those outpatient cases. So Medi-Cal is obviously a very important program for us, and we serve a very underserved population. Our hospital outpatient clinics offer a full range of specialty care to children, either seen us for the first time, seen us for a follow-up visit to an inpatient stay or an outpatient procedure, or seen us as part of an ongoing care regimen. Specialties include pediatric cardiology, cardiothoracic surgery, pediatric hematology and oncology, pediatric infectious disease, and a whole host of other specialty programs. If Valley Children's did not exist, children in Central California would need to travel elsewhere. They'd need to either go up here to Sacramento, the Bay Area, or Southern California to receive either inpatient or outpatient specialty care services. Our hospital outpatient clinics are clearly foundational to the care that our system provides. They play a critical role in maintaining or enhancing the health and well-being of the children that we treat, and in many cases, they prevent those children of having to access more expensive care in an inpatient setting, or if their care is not being managed successfully on an outpatient basis, they're going to wind up in our emergency department. When a patient visits one of our hospital outpatient clinics, physician and/or physician extender services are delivered in the space that's provided and equipped by Valley Children's Hospital, and includes our nurses and our medical assistants and a lot of other clinical and non-clinical services that they can only access being near the hospital. And that will include nutrition and social work and counseling and a whole other host of services that are important. In conformance with billing regulations and industry standards, Valley Children's bills a facility code to reflect these significant facility costs. Physician fees, of course, are billed separately. Examples of costs that are incorporated within this facility fee include our clinic staff who register patients for their clinic visits, do the follow-up, schedule the follow-up appointments, talk to them about processing their insurance coverage, facility fee will cover the costs we incur employing nursing staff to provide the critical education that these patients and their families need when it comes to understanding the treatment recommendations and following up with medication and treatment services at home. And then, of course, a lot of the overhead costs that we incur as an organization and being able to provide that full scope of very comprehensive services to our patients. If this bill were enacted and if our clinics were impacted, we'd lose $7 million in payment for the services that we're providing, and there is no other place for us to capture those services or in the costs for those services. So we're not billing for them separately anywhere else. So we would ask that you consider carefully the important role that hospital-based clinics play in providing needed services to patients, and that you preserve our ability to rightfully recover the portion that we are able to recover by charging the facility fee. So thank you.
Thank you very much. And we're pretty much up against time, so.
Mira Morton here on behalf of the California Children's Hospital Association, also opposed. Thank you.
Thank you. Other witnesses in opposition? Seeing none, we'll move to questions. I have Senator Mitchell, then Senator Roth.
Thank you. Dr. Hernandez, I get in reading the analysis and reading the bill what your motivation is, and Mr. Broad's experience notwithstanding. But the other examples that came to me that could be challenged are the Children's Hospital experience, as well as teaching or research-based hospitals where I may choose to go there because of the expertise of the provider. I've had experience at LA Children's Hospital where I chose to go there because of the doctor who didn't have, because of his teaching responsibilities and his supervisorial responsibilities over interns at the hospital, didn't have an off-site clinic. So in order to see him, I had to go to Children's Hospital and go to the Children's Hospital clinic. So based on the example here shared by Children's, based on research or teaching hospitals and their uniqueness in terms of trying to find a specialist that you want to see, help me.
Yes, and I understand, and as the opposition came in, I understood their issues, and I'd be willing to examine, entities like you're talking about, whether it's Children's Hospital who don't have, or a provider that doesn't have the ability to do that, see that patient in an outpatient or in their own office. So I'm willing to address it.
Thank you.
Then I have next in order, Senator Roth.
So for the proponents of the bill, like several other billing issues that I've heard here in this committee during the time that I've been privileged to serve here, isn't this simply not simply, but isn't this at least in part a disclosure issue?
Yes. I think it's a disclosure issue and maybe an issue where the same service is offered by the same entity, and at one place there's no facility fee, and at one place there is, that the entity probably should be required to let you know that you can have it done, the same service performed, 10 miles away at an office building that they own. For the average patient, you just go where they send you. It's not, and that was certainly my experience. So I don't think we want to get in the middle of children's hospitals, obviously, or we're talking about the provision of regular medical care where the choice of location within the same entity can have vastly different economic consequences for the same service.
So given that, why are we not dealing with this as a disclosure issue?
Well, I think that would be, as the bill moves along, I think that would be something that we would very much be willing to engage in with the opposition.
Because I'll tell you, one of my concerns, obviously I'm concerned about children's hospitals, and we have one down where I come from, or more than one. But I'm also very, very concerned about our county hospitals, our safety net hospitals. The hospital in Riverside County, as I recall last year, or the year before, was losing $50 million a year. I think they've done a turnaround down there, but as I look at this bill, and of course, we don't seem to have a lot of time to do background on some of this stuff before we're asked to vote, I don't know the impact on that hospital, because clearly the county hospital has outpatient clinics. The counties are allowed to employ physicians. I don't know how making this adjustment to those outpatient clinics that are co-located on the hospital grounds, what impact that would have on the hospital's financial situation. And I certainly need to look into that. Yes, ma'am. You want to clear me up?
No,
That's okay.
never correct you on your own hospital, Senator Bethel.
You may. You probably know it better than I do.
And the Hospital Association may have additional information. We're not clear that this occurs in every instance in California, but it has occurred sometimes. And so rather than have the experience that other states have had where it becomes the dominant approach, we thought it was important, since it is turning up here, which I was surprised by, that we proceed with the bill. So that's, and not to, so that's what the part of the emphasis was.
I see.
If I may, Senator, I would like to say that Mr. Broad's example is very unusual for a variety of reasons. Well, and
unfortunately, they have
just what you would expect.
But you have to understand that I think Mr. Broad is unusual himself. So that maybe that's kind of apropos for him.
I deserve that.
Thank you.
But it is, again, it's not a common occurrence. For example, the particular clinic, as we investigated this particular situation, we learned that the clinic he was at, half of the patients who go to that clinic are capitated. So there is no difference in cost for those patients. Probably 48%, the other half, minus 1% to 2%, are not paying that rate because their insurance has contracted a different rate. Medicare pays based on a fee schedule. So he probably is among 1% to 2% of the patients seen in that particular clinic.
Thank you.
And also, they had intended to notify him, and that fell through the cracks because he had a change in location, again, something unusual.
Thank you. Senator Pan?
Well, thank you so very much. I have to admit that I'm familiar with the facility, actually not as a physician who used to practice at UC Davis because that was a different site, but because I've utilized the C Street Clinic, so I'm familiar with what you're talking about. I am concerned with the way the bill is now, just sort of saying we're going to eliminate the facility fee, but is there currently, as you're working together, I mean, were you looking at trying to get to what I call, some people say it's site neutral payment system, so we have less confusion? I mean, I know that there's also about disclosure too, but personally, I'd like to see that we're moving in that direction, but I don't know whether that's a discussion that's happening, and your thoughts on the ability to land there.
Let me just kind of put in context how I view what I want to carry and why, and it's still about cost to the patient and if there's inefficiencies in the system. And obviously listening to the sponsor, I'm open to move it towards disclosure, how we get this so that an instance like this doesn't occur. Children's Hospital is unique, I get it, we will resolve that. But I'm willing to have that conversation, assuming it gets out of committee, to address, maybe to go down the route of the disclosure method as well.
And we have had some discussion on disclosure because that does make sense, absolutely. Also, I might note that Medicare is looking at this very issue, and Medicare has already noted that they will continue to pay a facility fee for hospital-based clinics that are in existence now, but going forward, they're going to pay a different rate. Those regs don't come out until July, and so I think that's something else we have to keep in mind. Medicare is doing some work in this area, and but we won't know more until sometime in the summer.
All right, well, that's certainly very helpful, and I hope that conversation will continue. Thank you.
I think we're at the end. I did have a comment leading to a question, and then we'll move to your close. I think the good news is that the testimony we hear is that this is a rare circumstance, or at least the circumstance encountered by the witness is a rare circumstance. So if that is in fact true, then now should be the time where we can work out both some disclosure and maybe some equalization. I can see a circumstance where a hospital-based clinic system, where if at a clinic that's part of or under contract to that hospital has unique equipment that maybe doesn't exist at the hospital, that you're sent there because there's a particular machine or equipment, that could justify a different rate, and maybe that could be addressed as part of an ultimate solution as well. But where it's really an outpatient setting that's not distinguished as a hospital setting, for the hospital to carry the facility cost and distribute it among all the clinics, that results in a spike to a patient's bill. That seems like what this bill is designed to try to address. So it's assuming that that's the path the author is headed in, I'm glad to be supportive. And with that, Mr. Chair, if you want to close.
Yes, and I've heard the opponents loud and clear. I've heard the direction of the committee, and because of the drafting issues, because this being the last hearing, I'm committed to working to make sure that we move towards a disclosure process. And, obviously, I'll let everybody know in the committee, but with that, members, I respectfully ask for an aye vote.
And I'll entertain a motion at this point. It'll be due pass to appropriations.
I'll move it.
We have a motion from Senator Hall. Clerk, please call the roll.
Hernandez. Aye. Hernandez, aye. Nguyen. Nguyen, no. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning.
Aye.
Monning, aye. Nielsen. Pan. Aye. Pan, aye. Roth. Wolk.
One more. Should be quick.
That's 5-1. While that roll is still open, did you want to weigh in on that? Not at this point. Okay, we'll leave it open. It's 5-1. That's enough to get out. We'll leave it open for absent members. Your final bill, Senator Hernandez, I believe, is item 15, SB 1471. And it does not appear that there's support on both sides. No opposition on file. So in the interest of the hour and a remaining bill from Senator Mitchell, would ask people to keep that in mind in your
I will accept
statements.
the amendments outlined in page 5 of the analysis, and then we respectfully ask for an aye vote.
Witnesses in support.
Thank you, Senator. Eduardo Martinez on behalf of the California Medical Association. Thank you to the author and his staff for working with us, and we are pleased to be in support.
Mr. Chairman, members of the committee, Randall Hager for the California Psychiatric Association. We are in support as well. Thank you to the author.
Great. Thank you. Any opposition? Others in support? Yes. Speak up. I think they'll get you.
Michelle Cabrera with SEIU California, and we're a support and concept. Thank the senator for taking this on.
Thank you. Any opposition? Seeing none, Senator Hernandez.
Ask for an aye vote.
This is due pass as amended to appropriations. Is there a motion? Have it from Senator Hall. Clerk, please call the roll.
Hernandez. Hernandez, aye. Nguyen. Nguyen, aye. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning.
Aye.
Monning, aye. Nielsen. Pan. Pan, aye. Roth. Roth, aye. Wolk.